Thank you very much to the organizers of the meeting and to Johnson & Johnson for the opportunity to participate and to speak about the consequences of an anastomotic leak in our patient and how we are improve our anastomotic outcomes with the new Echelon circular powered stapler. So, as you know, anastomotic leak is the complication that most concerns colorectal surgeons, and the anatomical location of the anastomosis have an influence in the anastomotic leak rates. In colorectal and coloanal anastomosis, the rate of leak can rise between 5 and 19%. I think, first of all, we have to think very carefully about the importance of have a consensus about the definition of what is an anastomotic colorectal leak in order to audit our outcomes and compare with the standards, in order to compare the rates of different studies. And in that sense, it's a very interesting paper published in World Journal of Surgery in 2020. It's an expert panel paper with 23 international colorectal surgeons, and they achieve a consensus in 80% of different categories. And one of the most important is the use of the same definition, the International Study Group of rectal cancer definition. But also using the same grading system is important. And probably we're going to speak later. The grading system also for the international group of study group of rectal cancer are the more used nowadays. So the leak have consequences. When patients have a leak, are going to increase the morbidity and mortality. They have an impact also in hospital stay and hospital costs. And in the field of oncological patients, the leak are going to impair the oncological long-term outcomes. Several studies have demonstrated that the mortality and the postoperative complication rate increase in case of anastomotic leak, not just in the short time. Also, we have to think about in long-term outcomes and the impact of the leak in the functional outcomes of our patients. This is a very interesting paper from the Sweden's registry, more than 1,100 patients with a leak rate of 7.5% after anterior resection for rectal cancer. And as you can see, the anastomotic leak is associated with permanent stoma, use of fecal incontinence, eye, and reduce of sexual activity. So we have to think also in the long-term functional outcomes of our patients. In case of oncological patients, the leak are going to impair the oncological outcomes. This is an systematic review and meta-analysis that show how in patients with rectal cancer, the leak are going to impair are going to increase the local recurrence. This meta-analysis include 14 studies with more than 11,350 patients, but not just the local recurrence. The leak are going to impair also the overall survivor and the cancer-specific survivor. But not just in rectal cancer, also in colonic cancer. Similar systematic review and meta-analysis with nearly 70,000 patients demonstrate that the leak are going to impair the overall survival, the disease-free survival, and the cancer-specific survival. So, but then, also, the leak have an impact in the hospital costs. They're going to increase. You see this slide, you can realize that depending on the country, depending on the healthcare system, but the impact of a leak can increase the hospital costs between 11,000 USA dollars 54,000 euros. So this is a very big economic impact in our institutions. So we need to audit our outcomes. We need to improve always, trying to find how to reduce our leak rates. And we have to think about that the causes or the risk factors are multifactorial, and there are a lot of patient-related risk factors and a lot of surgical-related risk factors, and also technology factors that have been described as risk factors for anastomotic leak. So it has been demonstrated that if you implement clinical changes in your daily practice, you can reduce your anastomotic leak rate. This paper demonstrates that this group start to introduce changes in 2010 and then start to improve the anastomotic outcomes. The first thing that we can do is to improve the conditions of the patients preoperatively. And in that sense, during the last years, several multimodal rehabilitation programs have been introduced in clinical practice with the aim of realizing rehabilitation intervention to optimize the functional capacity of our patients, the cardiorespiratory function, muscle function, trying to modify the risk factors, for example, the anemia, sarcopenia, the anxiety, smoking, and some comorbidities, and also to improve the nutritional status of the patients. And results of this kind of programs have shown that they are reduced abdominal complications after abdominal surgery, but we don't have yet good evidence that these multimodal rehabilitations, the speed that they're rational, can have a direct impact in reducing the anastomotic leak, but I'm sure that in the next future we are going to have some data in that sense. And also the way we prepare our patients preoperatively have an impact, have been demonstrated recently that the combination of the mechanical bowel preparation and the oral antibiotic prophylaxis reduce the risk of a leak. This is a very interesting paper, and this is a multi-center European study raised by the European Society of Coloproctology, more than 47 countries, nearly 40,000 patients. And you can see the combination with the mechanical bowel preparation and oral antibiotic have an anastomotic leak of 6.1 versus 9.2 with just the mechanical preparation and 8.7 without the mechanical preparation. So this is something that we can introduce also in our clinical practice to improve our outcomes. Also, some surgery-related factors can be modifiable. Of course, we don't have the location of the anastomosis. It depends on the position of the tumor, but we can, with our surgical technique, we can reduce the operative time. We can reduce the need of the blood loss and the need of or intraoperative transfusion that have been demonstrated that are a risk factor for leak. And also very important where we are making the distal transection, the distal control of the rectum in low anterior resections, the number of established findings that we need have been demonstrated that have relations with the leak. So we have to avoid to use more than 2 findings in order to reduce the leak of leak. So in general, it's very important to take care of the technical details to decrease the risk, the classical surgical principles that we have to pay attention for, like the free tension anastomosis and the good blood supply. So this is important also. Don't forget the classical surgical principles in order to a good surgical technique to reduce the risk. But technology factors are modifiable aspects and an important target for the risk reduction. So in the last year, we have 2 important technological advances currently available. One is the intraoperative assessment of anastomotic perfusion using the endochannine green fluorescence and angiography, and the other one is the new anastomotics device like Echelon circular power staples. I'm going to focus the rest of my presentation in our clinical experience with this new device. The new Echelon circular stapler have 3 technical improvements. 3D stapling technology, the gripping surface technology, and the powered firing. The 3D stapling technology allows or promote a better compression distribution through the anastomotic line, and the gripping surface technology make the pressure in the tissue just when it's needed to place the stapler, so reduce in 33% the compressive forces at the anastomotic line. And both the gripping surface technology and 3D stapler design are going to improve the healing conditions and the hemostasis at the anastomotic line. One of the problems with the manual staplers are the force required to perform to find the device. So this causes unwanted movements at the anastomotic lines that can make small vascular trauma and probably increase the risk of leak in the future. So the new design, the new ergonomic design of the stapler and the powered firing process providing stability and safety and decrease in 37% the anastomotic side movement during the device firing, and also the reduce in 97% the force required to fire the device, regardless the size or regardless the strength on the hand of the surgeon, and in my opinion also regardless the experience. So let me show you a short video showing how we make the anastomosis with this new device. That this is similar than the way we perform the anastomosis with the manual ones. The only thing that I want to show you is the ergonomy and the stability during the firing process, and as you can see here, you just have to press one small button. So again, is more stable and safety regardless the experience or the strength of the hand of the surgeon. Look at the stability of the anastomotic line during the firing process, and now here you can compare with the movement during the using a manual device and the stability with the new circular powered stapler. So with that, we decide to assess the impact of this novel powered circular stapler in our outcomes in the risk of anastomotic leaks in colorectal anastomotics. And we conduct this cohort study from January 2017 to February 2020. We start using the device in June 2019. And we go back to January 2017 to look the control group, because we maintain a prospective database during the last 10 years, and we go until January 2017 because during all this period we have used the same preoperative and postoperative protocols. Also, the same group of surgeons has performed all surgeries, all of them colorectal surgeons with more than 10 years of experience. And the only change we have introduced is the new device. We have used as inclusion criteria patients over 80 with colorectal stapler anastomosis for benign or malignant pathology for open to laparoscopic approach. As an exclusion criteria, the anastomosis lower than 5 centimeters from the anal burst, reversing stomach, perioperative radiotherapy as a score more than 4, and in cases where we have used the TANMI approach. So 279 patients met the inclusion criteria, 61 Echelon circular powered stapler group, 218 in the manual one. So we use a propensity score in order to find two completely comparable group of patients with the matching algorithms nearest neighbor ratio 2.1, and we use as a covariate other risk factors like age, sex, body mass index as a score, preoperative hemoglobin, the Charlson index, diagnosis, and surgical approach. And we have at the end two completely comparable group of patients, 119 in the manual one and 60 patients in the Echelon circular powered stapler group. So the main diagnosis was rectal cancer, followed by sigmoid cancer, Hartmann, diverticular disease, and left colon cancer. The surgical technique, anterior rectal resection and sigmoidectomy, but also we have cases of Hartmann reversal and left colectomy. In 51% of the cases, the anastomosis was placed between 5 and 10 centimeters from manual birth, and in 49% of the cases between 10 and 15. And as we have mentioned at the beginning of the presentation, it's important to use definition with consensus. In that case, we have used the International Study Group of Rectal Cancer anastomotic leak definition. That is all the defect of the intestinal wall at the anastomotic site leading to a communication between the intra and extraluminal compartment, but also with any abscess or collection adjacent to the anastomosis. And we have used the grade system A, B, C. Grade C is the leak that requires surgical treatment. Grade A and B are minor leaks that can be treated by a conservative treatment. And we perform an endoluminal contrast CT scan, of course, always in case of clinical signs or suspicions of a leak, but also routinely we check the CRP in the 4th postoperative day and is higher than 200. We perform also the CT scan with endoluminal contrast. This, I think, is the way to make the proper diagnosis of the grade A and B leaks. These are our outcomes. The overall anastomotic leaks 9%, overall anastomotic leak that requires surgical treatment 6.4%. The risk of a leak is higher in patients when the anastomosis is done by a manual stapler versus the new Echelon circular stapler. And if you compare outcomes between the two groups, the anastomotic leak rate is 11.8% in the manual group versus 1.7% in the Echelon circular group. In the manual stapler group, 5.8% have been anastomotic that could be treated by conservative treatment, and 5.8% are a grade C leaks that require surgical treatment. The leak in the circular Echelon circular group was a leak that required surgical treatment. After our study, there is an interesting paper also with including 12 centers from USA and Europe with consecutive surgeries and one left cyclorectal anastomosis. And all the anastomosis have been performed with the new Echelon circular power device. And as you can see here, there is just, they include 168 patients with 12% of performance issues related to the stapler, and with an anastomotic leak rate very similar to ours, 2.4%. And after the same group of patients, or this other there's a new publication about this, the same series of patients using the same design that we have used in our study. And they take the control group from an international, from a United States database. And as you can see here, the rate in the Echelon circular power stapler group is 1.8 versus 6.9 in the control one. But let me share with you our current studies. We have modified a little bit the inclusion criteria. We have introduced also the elective emergency surgeries performed by a colorectal surgeon of our team. And we have eliminated the level of the anastomotic as exclusion criteria, the diversing stoma, and the perioperative radiotherapy. We have included another other exclusion criteria, that is the general surgeon. So we have now all the left side anastomosis that we have performed with the new device, and with the same design. Now we have used the propensity score, and at the end we have two completely comparable group of patients with 165 in each group. And as you can see, also the improvement is clear. 4.8% of leaks in the circular stapler group, and 13.33% in the manual one. So with more complicated cases, we have a little bit increased the risk of leak, but the difference between the manual group and the Echelon is clear. So in other words, for every 12 patients treated with, we prevent one anastomotic leak if we use the new device. but the speed, the improvements in the preoperative manager of our patient, our surgical technique and the technology, we still have the anastomotic leaks, because the leaks are the result for a complex and dynamic interplay of several factors and biological processes. And probably in the next future, advances in the knowledge of the role of hot genetics, gut microbiome, inflammation, and immune system are going to help us improve a little bit more our anastomotic outcomes. So as a conclusion, anastomotic leaks is a complication that most concern colorectal surgeons. Identifying factors which may affect anastomotic outcome is important in reducing the incidence and clinical impact of anastomotic complications, and technology improvement are potential targets for risk reduction. Our experience with the Echelon circular port stapler shows that it could have a positive impact in reducing anastomotic leak rates in left side colorectal anastomosis. And multicenter control trials are needed to obtain stronger evidence and justify clinical practice. Thank you very much for your attention.
Thank you. Thank you so much, Professor Marti. Are you here?
Hello.
Hi, hello. Good morning. Good morning to you. I think it's a very early morning for you. Thanks for joining us in the live Q&A sessions for this lunch symposium. Congratulations for very, very impressive lectures and the success of your cohort studies. Really excellent. So I think now the lecture is open for questions and answer from questions from the floor. Any comments or questions? Maybe I get the ball starting this question first. My first question is, so far there's at least three retrospective study, propensity score matching studies show that there's some positive result for power stapler. I just wonder, for your studies, do you think there's any selection bias because the power stapler is a newer device, therefore maybe some of the benefit is because of the learning curve for the surgeon? What do you think? Do you have ways to reduce this bias?
First of all, thank you very much for the opportunity to share with all of you our results. It's a great pleasure. Yes, I don't think that in our studies the factor of the learning curve have an impact, because we are a colorectal group of surgeons with more than 10 years of experience. And if you have a look about the study period, it takes from 2017, because we have, of course, when we perform the propensity score, we're using patients with the manual stapler that are retrospective patients, but just in that we have come back until 2017, because all the perioperative protocols are the same, and the same group of surgeons have performed all the surgeries, and again with more than 10 years. So no, the learning curve, I think, is not an impact here. I mean, a propensity score, it gives you a level of evidence quite similar to a randomized study, because you are going to find a similar patient from your database that each particular patient that you have in the group of the Echelon circular stapler.
Yeah, thank you.
And we have eliminated in our studies the general surgeon that can have performed some procedures, mainly in the emergency circumstances, to avoid that bias about the surgeon or the experience of the surgeon in the outcomes.
Thank you. Any questions, comments?
Hi, Prof. Just one question as well. I think typically when we use the manual staplers itself, I think what we learn is that you need to give some time for tissue compression for the edema to settle. With such a automated system, does the system factor this in for the time before it fires? And also, in terms of the second question being cost itself, I think that there'll be more towards the J&J itself, whether or not in terms of cost differential between the manual and the new stapler itself, what's the difference itself? Because I think that will translate to our clinical practice, whether or not we use it.
Yes, thank you. Yes, the main question, the way that you perform the anastomosis is quite similar. You have also to wait a little bit in order to achieve a good compression of the tissue. So there is no a big difference in technique. The big difference that you are going to find just in the first use is the stability and the ergonomy and the fighting. But in my opinion, probably they have a higher rule in the improvement of the outcomes, the gripping surface technology, and the 3D stepper design, because you make the compression just where it is needed to place the stepper, and then you are going to decrease the compression in the anastomotic line, improving healing conditions. For me, is important. This is the hidden advantage of the new technology. The most obvious advantage is the ergonomy and the stability because of the powered fighting, but the compression of the tissue probably is more important with the new chains. But when you are performing the anastomosis, you know, the technique is very similar. You have to wait a little bit in order to avoid the edema, but just when the stepper are going to place, instead that in the anterior anastomotic line, that I find is a good point of the new device. About your second questions, yes, you're right. Unfortunately, all the new technology are more expensive than the previous one. We have always to fight with our hospital manager in order to introduce all the new devices. I think we have the same problem in all countries. So we have been in the same circumstances. I think it's more or less 35% more expensive, the new device, than the previous one. But of course, if the improvement of the outcomes are clear, so the cost of one leak is much higher than the impact of the increase of the device. We are now preparing an economic impact study, and for example, we have checked the economic impact during our study period for our hospital. If you think about the leaks that you are going to avoid, the economic savings for our hospitals were 200,000 euros. So it's a big difference. No?
Certainly.
So it depending on the health system and the country you're working, the cost of leak, but it's around 40,000 euros in our environment. So if you avoid one leak each 12 times that you are going to use the new device, so you are going to spend 35% more in the device, but you are going to save a lot of money to the hospital. So I think from the economic point of view, is a very, very good balance. So leaks are very expensive.
Thank you. I think for the interest of time, I think we have to end this symposium, but I really want to congratulate you. Put so much efforts and study the new device and scientifically by conducting multiple studies and before we implement it into the general practice. Congratulations, Dr. Marti, and all the best for your career. Thank you. Thank you so much.
Thank you very much. Real pleasure.